But in Vietnam, as I know, in Vietnam, the ultrasound is very common, and they do ultrasound in most of the disease diagnosis. I think that's.
No, but it's special.
Yeah, they
like
use
it
ultrasound
depends.
for staging, or they use ultrasound for primary diagnosis. What the indication for ultrasound in Vietnam? What they use it for?
Yeah, because the ultrasound is easy to do, easy more than CT scan, and cheaper and faster, and the cost of the ultrasound is lower than CT scan. So in Vietnam, the ultrasound in maybe the doctor like ultrasound.
Sorry, he asked like, is it for you mean like the ultrasound for this case for confirm about the staging, or I mean like about the lymph node? I mean, is that this cancer, or you ask about the primary ultrasound for the make another diagnostic for different disease? So what specific things?
Because I said that, for example, in this case is gastric cancer, and we do the next step. Next step is staging, and
Staging,
yeah, and ultrasound can see the liver, see the lymph nodes. Yeah, lymph node in the abdominal. In abdominal. So I don't know. I don't know. Can we do abdominal ultrasound in this case or not?
As I told you, we can do ultrasound. We can. But I say there's high false negative. That's what I'm talking about. When you have that option, you can't depend mostly on that. That's what I'm talking about. You just use it for like a limited stage. Like it's not till now metastasized. It's just like cancer. That's just mass in the stomach. That's okay. We can use ultrasound. But how you know it's advanced or not? How you know where's stage, where's the metastasis? That's why we use CT scan for staging. That's the We can use ultrasound anywhere, whatever where. But what's the high percentage of false negative? Like in gallbladder, gallstone, what the highest the diagnostic is ultrasound. Is that right? More than CT. Yeah. So at that time we used ultrasound. Is like 99% sensitive. sensitive. In gastric cancer, I think the sensitivity is less than 70 or 60. That's why we can use it, but the sensitivity is less.
72.
That's what I'm talking about. You can use ultrasound anywhere.
Yeah. Thank you so much.
Thank you.
So we move to the next question. Okay. So our time. Okay, Bon, can you help us read that question, please?
Okay, I think that I've been silent for so long.
Please keep the microphone here.
Okay. Can you hear me clearly?
Keep phone. We can hear you clear.
Okay.
Yes, thank you.
Can you hear me clearly?
Sure.
Okay. And a 40-year-old woman comes to the physician for right lower abdominal pain for 6 months. She has multiple non-bloody watery bowel movements daily and experiences abdominal cramping. Sometimes she feels sudden palpitations. Is short of breath and her face becomes red. She has lost 7 kilograms over 3 months. She went on a 3-week hiking trip to Cambodia 6 months ago. She has smoked a pack of cigarettes daily for 15 years. Her temperature is 37 degrees. Her pulse is 72 and her blood pressure is 125. 5/60 military mercury. On physical examination, tiny blood vessels are noted on her face and arms. Lung auscultation shows bilateral wheezing. The abdomen is soft and non-distended. There is localized tenderness to the right lower quadrant, but no rebound tenderness or wording. Laboratory studies show, which of the following is the most likely diagnosis? A. VIPoma. B. Chronic appendix. Oh, sorry.
Appendicitis.
Appendicitis.
Yeah.
C. Ascaris lumbricoid.
Ascaric
infection.
lumbricoid.
D. Ascaric lumbricoid infection. D. Pheochromocytoma. Oh, I'm not sure about this word.
Pheochromocytoma.
Pheochromocytoma. E. Inflammatory bowel disease. F. Carcinoid tumor. G. Bronchogenic carcinoma.
So do you guys know about the ascaric lumbricoid infection?
Yes, I know this. It's a kind of
Parasite.
Parasite.
Oh yeah, parasite.
Okay. Yeah. So go ahead. Dr. Hassan, you want to ask anything?
So, what you see, as I say from the beginning, when you read any question, the sign and symptom.
So today we learn about signs, symptoms. Okay, go ahead with that.
The question now. Anybody see something? Patient have multiple non-bloody diarrhea, abdominal pain. You feel sudden palpitation. That's all symptom. Short of breath. His face, or her face, sorry, become red. She lost 7 kilos.
That's the symptoms, right, sir?
Yes, that's all symptom. He complained about all of them. Now what we see now. On physical examination, we see tiny blood vessels, lung auscultation, bilateral wheezing. Okay.
There's tenderness on the right lower
On
part.
the right lower quadrant, yeah.
No rebound.
No rebound. That's mean what?
I think
The
she may have
No
parasite.
No,
Because-
yeah. That's
She had shipping to Cambodia 6 months ago, and she have weight loss. It can be a symptom. In a physical examination, tiny blood vessel are noted, and lung auscultation, so between wheezing, it can be a symptom of hypersensitive.
symptom of what?
Allergies.
Allergy.
Allergy.
Activity. That's
What? Right?
Allergy.
Yes, allergy.
Okay.
And in the laboratory, eosinophil is 2%, and it's elevate. Normal value is I know is 0 to 1%.
Mhm.
So I think she has a parasite infection.
What will you see in the lab work? What you will see? You say parasite. So what you will see make you feel like it's parasite. What the main part of lab work you can see and you can diagnose this is parasite.
The
It's very
main
important.
eosinophil.
Eosinophil. The
It,
eosinophil is normal here, 2%.
Yes.
Is that right?
It depends.
So that's normal. That's mean not parasite. Eosinophilia is 2%. So that's normal. 1 to 2% is normal. So we take this diagnosis away. It's not parasite.
So the value of eosinophil here is normal, like it's not elevated long. Yeah.
So it's not parasite.
Mm-hmm.
So from the question, what they say here, there is no rebound, tenderness or garden. That's mean it's not appendicitis. So so choice B is out because of that. It's not appendicitis. From the question.
So
What else?
Rebound. Yeah.
What we see
we
in the lab work, there is something you can see.
Elevated liver enzymes.
Yes, good job. So you have elevated liver enzyme. You have on lung auscultation. You have bilateral wheezing, high liver enzyme, weight loss, diarrhea, abdominal pain, flushing. Let's say flushing. We're not say like he become red. He say I become red when I have that, but that's been flushing. He had face flushing. So all those sign and symptom.
Sound like carcinoid tumor to me.
Carcinoid tumor. Good job. Is that right, Dr. Tong? That's the answer. Carcinoid tumor.
Yes, of course.
That's the only one. Yeah, that's the only one which share all those features together.
Mm-hmm. Carcinoid tumors, and pay attention to the symptom here. Like patient have the red, like her face become red. It's been flushing, and this is a symptom of like about the endocrine symptom. We call like
neuroendocrine.
Yeah, neuroendocrine. Yeah. So I believe not many people in here. We didn't have many cases about a carcinoid tumor, right, Dr. Hoyne? I think.
Yeah, because, I think the percentage everywhere is rare. It's not like it's common. GIT carcinoma. I mean, it's mostly middle age, not old age, middle age. That's why they say 40 years old woman. And I think I read something about it's more in women than in male. I think I read that somewhere. I don't know if I'm right or wrong, or somebody have any other idea. I read that mostly in more, I don't know the percentage, 3-1 or 2-1. I don't know where I read that when I was struck about carcinoid. Yeah. Yeah.
Patient also have diarrhea. That's also another symptom of the carcinoid tumors.
Yeah, usually when I see a patient have flushing and diarrhea in the lab work, it's kind of normal. It's like carcinoid syndrome. It's like and then usually is metastasite. If it's in the liver, then you probably have elevated liver enzyme because usually metastasite to the liver and cause some symptoms. Shown as a breast.
Yeah, you are right. Yeah, mostly when you diagnose, it's being metastasized.
Ismail, like when patient come to see us and get the diagnosis, usually patient have the metastasis, right? Mm-hmm.
Localized, hard to diagnosis unless, as I say, always we'll go with mechanical symptoms. That's the only sign and symptom we can diagnose, or accidentally we diagnose the disease by upper or lower GIT endoscopy. But mostly when he complained about this patient have lung wheezy, lung auscultation, he had diarrhea, flushing, that's all, and high liver enzyme, that's all metastasized. Okay.
So any question for that? Just ask, like, if you are not clear about this stuff,
I have a question.
Yes.
What carcinoid tumor associate with? There's a heart valve problem that carcinoid tumor associate with. I forgot what it is.
You mean like the valve, the heart valve, right?
Yeah, he say it's affect the heart, valvular heart.
Mm-hmm. So which is?
Mm-hmm.
Tricuspid valve, right?
Mainly the right side. Right side.
The right heart.
Right,
mean the
right
heart,
heart side.
Yeah, it's all. And he asked about the valve, so that's usually related to the tricuspid valve, right, Mr. Leo?
There's actually both. There's either tricuspid or pulmonary, so it's right side heart valve.
Wow, both.
What side of the heart has usually been affected by carcinoid tumor? Kind of forgot, so thank you for a reminder.
Yeah, the right side of the heart, and the tricuspid valve and pulmonary valve too. Okay.
My question is why the patient become red or flushing, or why become diarrhea? So we say neuroendocrine tumor.
Good question. Anyone know about this?
Yeah, because we say neuroendocrine. Yeah, sorry. Go ahead. Who wanna talk?
One more again. The questions.
Yeah, the question is why the patient become diarrhea and face flushing. Let's say he become change red.
Cutaneous flushing.
What caused all the symptom to the patient?
Was that because of serotonin release?
Yes. Yes. Good job.
Correct.
Serotonin.
As
we say, it's neuroendocrine. That means the tumor release some endocrine hormone.
Yeah, the carcinoid tumor can release serotonin.
Yeah. In this case, the symptom, the carcinoid symptom is typically because we have the most of the symptom of the carcinoid syndrome. But for in the Vietnam, sometimes we do not have the all of the symptom in the patient. So it's very difficult to think about the carcinoid syndrome as the first time, because the Vietnam is the tropical country. So with the patient in the middle age, come with the diarrhea and some of the symptom like this. Most of doctor think about the maybe I agree with Long. Think about the parasite first, parasite or something about the infection first, because as my opinion, the carcinoid syndrome is not common. Because in my hospital is until now I just see some case, maybe 3 or 4 cases with the carcinoid syndrome not common. So it's very difficult to release recognize that in the first time. I think so.
Yeah, I have never seen carcinoid tumor. For 2 years go to clinical, I don't see any case like this.
Yeah,
So-
as I say, it's very rare. Yeah, very rare.
It is very rare.
Yeah,
But at least we know about this to make sure in our clinical practice. One day we'll, like, who knows, we'll meet that patient, and if you
Yeah.
can give diagnosis for the rare case, it means you are very excellent doctor.
Yeah, I think it's changed.
Dr. Thong, sorry, it's not like that. It's mostly accidentally diagnosed. Accidentally. Mostly, it's slow grow tumor. Very slow, by the way. When he have sign and symptom in the question, they say 6 months, but does not mean he's from 6 months starting have the carcinoid. It's like 10 years before. I mean,
long progress.
10 years before, because it's very slow grow tumor. Very slow, very slow.
Yeah,
So-
usually when you have symptoms, I think it's already metastasis. That's how.
Yeah, so that's why the question, like we had the whole sign and symptom of metastasis, like he reached to the lung, heart, reached to liver, so everywhere. That means at that time it's easy to diagnose.
Yeah, one more thing about the location of the tumor, like carcinoid tumor. Actually, it's not only in stomach. Right here is this case like gastric cancer. It can happen in another place, like in the intestine, or even it's the lungs. Or yeah, can happen in everywhere in our bodies, like Dr. Hassan said.
Like this patient have like metastasis to the ileocecal. That's why he had pain, and we confused with the appendicitis and the lower quadrant. Yeah. So that's why we didn't differentiate with all those options, like they say, because pheochromocytoma have two. Some people they have a red face. That's why they put pheochromocytoma here and option D to make you confuse. If you can't, the patient has no normal blood pressure, and they put bronchogenic carcinoma here in the question because the patient have wheezy chest. So, and they put inflammatory bowel disease because the patient have diarrhea, nervous diarrhea, because maybe it's Crohn's disease, and Crohn's disease sometimes have lower quadrant pain. So that's why how we differentiate between them depending on the sign and symptom of the patient, and how we can read the question well to differentiate with the lab work. Yeah.
So for the last choice here about the pheochromocytoma, this is also neuroendocrine tumor, and it's a release of catecholamine, and this like it can make like flushing, but in this case not like the whole thing.
You have no blood pressure. That's why I rule out pheo. Pheochromocytoma is a secondary cause of hypertension.
Yes.
So patient have normal blood pressure, so it's out.
So we should not think about this at all. So any question?
Also, well, on the Ascaris lumbricoides infection, usually I see one in the ER when usually patients have diffuse abdominal pain, not just one quadrant, because it's obstruction. And X-ray usually reveal multiple bowel gas above it. It's like mechanical obstructions. And as Dr. Hassan said, the eosinophil is normal, so 1 to 2% is still normal.
Usually more than 5.
more than 5% is considered abnormal in the US, at least, I think.
You don't have that, yeah. That's scarce. Yeah.
Any question? Okay,
Yeah.
so
I have one question.
Yeah, go ahead.
Yeah, I have one because I hear about long status. The patient with peptic ulcer can develop into the gastric cancer, but I don't think so. So I want to ask, is there association between the gastric cancer and peptic ulcer?
Peptic ulcer and gastric cancer, how correlate between them?
Yeah.
How we differentiate or correlate? What do you mean?
Correlation.
Correlate. You mean with the sharing feature between them?
I think he asked how the gastric ulcer can develop into gastric cancer. That's what I'm trying to. So I think it's all related to inflammations, because chronic inflammation can cause metaplasia of the cells, and usually in the stomach is I think it's adenocarcinoma can develop from chronic ulcer because chronic metaplasia. That's what I think. I don't know what you guys think.
Depending on the cause of the ulcer, if it's H. pylori, it's go to lymphatic. I think lymphatic.
What you said?
I say if it's the cause of ulcer, H. pylori.
So it depends on the cause. So if it's the patient has the peptic ulcer with the H. pylori, so the risk of the gastric cancer is increased with that. Okay.
Yeah, just think about like the cell of the stomach. I think when we talk about cancer, how it develops is like constantly cell replication, and if you have chronic inflammation in your stomach, the cells keep the replication cycle over and over and over again. Some of them will just become mutate and turn into a dysplasia, and then for a long time it's become metaplasia, and then it's turned into adenocarcinoma of the stomach. And H. pylori, I think is keep the stomach acid really high, so it's damage to the cells and stuff like that. So constantly cell death and replication cycle may develop the cells into cancer.
As I know, until now there are no evidence to make sure that the gastric the peptic ulcer to develop into the gastric cancer. No evidence. But the gastric cancer and the peptic ulcer have the same risk. This is the H. pylori, and both of them have the same many of symptoms. So we have easy to mistake between the gastric cancer and peptic ulcer, but no evidence to say that the peptic ulcer develop into the gastric cancer until now. So when we have when we do the endoscopic and see the ulcer, we just do biopsy, and biopsy can make sure that this is a ulcer or this is a cancer. It's maybe it's bad.
Yeah, I think that's what we do here too. Correct me if I'm wrong, Dr. Hassan, because
we cannot say the gastric cancer long time can make the peptic ulcer in long time can make the gastric cancer. We cannot say that. We just this is the same.
Yeah, I know that.
We cannot say like that's a risk factor. That's not risk factor at all. But like like Mr. Leon said, like it's also like not wrong. Like for the peptic ulcer, for long term, we can have the increased risk of malignant transformation, and it's have the 5 to 10% of the case they can have the malignant transformation. And especially like Dr. Hassan said, if the patient have the peptic ulcer because of the H. pylori, I mean HP, they can highly increase the risk of the peptic ulcer the gastric cancer in the long terms.
Okay.
And what Hoàng say, I think, is also right. Correct me if I'm wrong, Dr. Hassan, because when I'm on my GI rotation, whenever we have a patient with suspected gastric ulcer, we usually take a biopsy along with the endoscopy whenever we do the endoscopy.
That's the question. Sorry, again.
That's your idea, your question, your
Oh
sharing.
no, I'm just confirming because when I'm on my GI, whenever we suspect gastric ulcer, we just do endoscopy and take a biopsy in the case.
Absolutely right. Yes, that's the primary diagnosis.
So
that's what we differentiate between ulcer and it's cancer. And this, that's the first case in my life I saw that the patient have hematemesis, and after he stopped bleeding, when we do the endoscopy, we discovered he had gastric cancer. That's first week in my rotation. So I was like, that's first case in my life.
Oh wow, that's amazing.
Yeah, we don't know. Yeah, that's first case, which I see was very serious. He was bleeding, and when he stopped, when we do endoscopy, not me actually, it's my professor. So and then after that, when I hear about the diagnosis, they say he had gastric carcinoma, and he had mass, and they do the resection because of that. So it's accidentally they discovered that.
Yeah.
That's crazy.
Yeah.
So let's take a look in overview about the symptom or something in here. Dr. Hassan just talked very with more information about this disease. Just give the some participant who touch on this talk, so you can take a look at it and summarize for us, or whatever is table.
Again,
you see the master screen now?
No.
No? What?
Yeah, I can see.
Yeah, that's interesting.
I'm not familiar much with Zoom. That's why the reason. Not familiar with Zoom.
Okay, just go ahead.
Thank you. I saw one really high yield point on that thing. Is virtual clean notes. That's I think that's very high yield.
So as we say here, that's the last thing about the gastric cancer. As you see here, we not talk about the late stage gastric cancer. What we see, that's when the patient come in, after all, what we see after metastasis. So as I say, gastric outlet obstruction, hepatomegaly, ascites, virtue node. That's after we do CT scan, we can discover that. That's, as I say, we cannot use ultrasound for diagnose all those lymph nodes everywhere. So the CT scan is the main diagnostic option for us for staging, because if we discover those nodes, that we know the patient is in late stage. That's it.
Okay. Just that. So about this is a diagram.
Yeah, I talk about that. As I say, did you see the CT scan? We can use
when
the
you're talking
abdominal
about,
ultrasound.
like you talk about this slide, let's talk about the previous slide.
Yeah, we say about that, and when we do biopsy, we can see if it's the biopsy is negative. That means it's benign. It's positive. That's mean adenocarcinoma. And after that, we use for the staging, as the doctor say, we can use ultrasound in Vietnamese. As I told him, there's a high false negative.
Yeah.
But the CT scan is the main one we can use, because if it's limited, we can diagnose the CA is limited, like still in the primary stage or advanced stage, depending on what we see in a CT scan. Okay. So depending on what we see, we can give the treatment. Like we do with resection, chemotherapy, radiation, depending on the staging. This give us option for the treatment. That's why we use the CT scan to give us option what we treat.
Yeah.
Only surgery after. If it is highly metastasized, we just go with chemotherapy. The resection is useless at that time. That's why. This is stage 3 or stage 4. The surgery is the last choice. We do not use it. So we just go with chemotherapy or radiation. So that's the why we go with the staging.
Okay, so it's only here about the histology. So anything to talk in this picture? Dr. Hoang, I think you're good in that, right? Because I know you have studied pathology before.
Yeah, I have 1 year to study about the pathology, but
it's a difficult picture.
It's difficult to explain the some size of the cell.
Okay, sorry, I chose a very bad
Yeah.
picture. Okay, let's see if we can help you. I think this picture for
I think it's hard from that to diagnose from that. It's hard to me to know that's who stage this now. We can.
Not to talk about the stage.
Behind is so long.
We can see the cell arranged in the round, like the round, like I can't understand. The cell arranged in round, many rounds, and we can see the nuclear of the cell is very big. Yeah, and some big and dark than the normal cell. The normal cell, the nuclear is smaller and maybe light. Yeah, but in this case, the cell can arrange in the around. So I think this is a good differentiate maybe in the
well circumstance. You mean like
well differentiate
circumstance, like you can, it's not like invasive to another place, like what you mean?
No invasion.
Okay.
Well differentiated. Yeah. I just say
that. That's good. That's good point. Okay. Okay, so I think this is also enough for the talk today. If you guys have any question for that.
Yeah, it's okay for me.
Okay, that's good. We discussed lots of things today. So let's talk about next week, or even in the next time, what you guys want to ask Dr. Hassan can make the talk with us with another topic, because he's a what's he? Again, can you tell us again your specialty?
Yeah, it's good if something related to my specialty, anything related to anesthesia.
Anesthesia and ICU. So it's better. I know that. But he's also good at internal medicine. So you guys can suggest about a topic and ask him about like ICU or even this anesthesia. What you can suggest us, Dr. Hassan, like what topic you want to share with us?
Yeah. So if somebody asks about the complication of some medication, or yeah, patient have sleep apnea. Some people they awake late. Why? There's a lot of things for anesthesia. Yeah, some medications affect the physiology of the body, how it's affect, with the side effect. Yeah, yeah. How we give maintenance, induction. There's a lot of things to go with. That's the easy things for a student. But there is some advanced things it's hard to go with. But if they have any question, that's okay.
Yeah. Okay, thank you so much. Yeah, just like we asked you about this, and next week I think Mr. Leon will become the host. So let's ask him about the topic. What do you want to share with us?
Well, I don't know what I'm gonna do yet. You guys tell me what you guys want to do.
Okay, so we can do cancer again. I feel so. Maybe sometimes I feel like a lot of cancer. Maybe the participant feel boring or feel like we need more topic or another topic more.
You gotta get more with cancer yet?
How you guys? So like pick another topic in next week and ask Mr. Leon will become a host with that topic. Okay.
Yeah.
So
yeah, I will research about that topic and then
we have more than 200 kind of the cancer, so we don't.
Yes,
we can say.
So yeah. Yeah. Okay, so thank you so much for your presentation today, Dr. Hassan. We really appreciate your time with us. Maybe take more than 1 hour. And we hope in the next time, if you have free time, you can become a host and share with us about some of your knowledge. And we really, really love that. Okay, thank you so much.
Thank you very much, sir. I learned a lot today.
Oh, I learned too from you guys. Thank you so much.
Yeah, thank you.
Okay, so see you guys next week.
Okay, bye.
Bye-bye.
Bye.